2D echocardiography, and the today's speaker is Dr. Vivek Kumar. So Dr. Vivek Kumar is very well known in the field of echocardiography. Actually, he needs no introduction, and it is a pleasure for everybody else to hear from him. And today's topic will be very much interesting because it's a case-based discussion, I suppose. And I request everyone to make this session very interesting at the end of the talk, particularly the DNB fellows and our IDCCM and other fellowship students. So, Dr. Vivek Kumar was working with HN Reliance Hospital, and he is the one of the associate director there. And with us, my colleague Dr. Akhilesh from Apollo Hospital, Bombay. He is the moderator. I am Dr. Gunadhar, coordinator and in charge Apollo Hospital, Navi Mumbai, critical care department. And we have few other panelists with us. I don't know whether they have joined because Dr. Kedar Turaskar, due to some reasons, actually he's not able to joining today. And Dr. Anup, actually Dr. Anup is the cardiologist in charge with us. So he'll be also one of the panelists. And with us other panelists, I think from Nagpur. So let's not waste the time and start the session.
Yeah, we have Dr. Deepak Jaiswani from Nagpur. He is Director of Intensive Care, Critical Care Hospital. He is also has been doing 2D echocardiographies, and he has ECMO center also. So, and he is now a pioneer in Nagpur, where he is the first to do 2D echocardiography and incorporate 2D echocardiography in the clinical practice. So he will be joining late. So welcome, Dr. Deepak Jaiswani also.
Okay. So
and we have Dr. Alokik Goel, who is our associate at Apollo Hospital, Navi Mumbai. Dr. Alokik Goel. Welcome, Dr. Goel.
He's not able to join because of I think he's stuck up in the duty.
Sure. Without much ado, I think we should hand over this to Dr. Vivek Kumar. Welcome, Dr. Vivek, and let us begin the session today.
Yeah, thank you, everyone. So sorry, I could not put a topic slide. So, but basically the topic is sepsis and the heart. And the way I have done it is we will.
Can we mute those who are?
Please mute whosoever it is.
Yeah.
I think somebody's.
Yeah, Mithra, can you mute everyone except the speaker actually?
Yeah. Mute everyone till the end. We'll take the questions in the end only. So basically there are 5 cases on sepsis. So we have 5 cases where we have the echo loops on sepsis, and I'll try to keep each case over 5 to 6 minutes. And at the end of 5 cases, we have a putting it all together slide, which will run for another maybe about 20 minutes. At the end of it, we can discuss everything. And I have tried to incorporate it so that it answers most of the question. Basically, by the end of this talk, you should be able to manage a case of sepsis using echo-based hemodynamic monitoring, and you should also be able to prognosticate appropriately. So in the first case, it was a patient of sepsis with dyspnea, and the indication for ICU echo was acute dyspnea. Admitting diagnosis was urosepsis. It was day 1 of illness. Comorbidity illness were type 2 diabetes, primary hypertension, coronary artery disease, CVA, and CKD5. So when you have a patient who's diabetic, hypertensive, and has a CKD, what do you expect in the background is that he should be having left ventricular hypertrophy with diastolic dysfunction. That means these are patients who come in with a stiff heart. Okay, and the patient was not on ventilation and not on vasopressors. The vitals were RR 26, SpO2 94, BP 110/60, pulse 105. Sorry. So this is the plaques view, as you can see here. It appears like a very briskly moving heart, And the other thing which is very prominent is that the aortic valve, it appears sclerosed. And from the plaques view, we measure what is known as the LVOT diameter, which we measured. And then we went to the apical four-chamber view. And in the apical four-chamber view also, we found a heart which was moving quite briskly. Okay, the gains are a little more in this loop while it is playing, but it's a heart which was moving quite briskly. And then we took another cut across the apical four-chamber view, and it showed us exactly the same thing. Okay, the heart does appear a little dilated, but then it was moving quite briskly. From the apical four-chamber view, we took the mitral inflow pattern where we saw the E wave and the A wave. The E wave is the first wave here, and we found that the E wave is much smaller than the A wave. It's 1/3 of the A wave. Typically in diabetics, hypertensive CKDs, you expect the E wave to be much higher than A wave. So there was a presumption maybe, you know, this patient has lost some volume and that's why the height of E wave has come down. We also could get a loop across the pulmonary vein where we saw that the first wave, the S wave, is less than D wave. That means definitely there were some increased pressures in the left atrium. We took the LVOT VTI. Now, if you see here, this is not a very classical loop. If you look at it in a classical LVOT VTI, first of all, there has to be more clarity. The envelope has to be white and inside has to be black, which is not there. And then you can see here in the loops, we have a opening click and I have a closing click. Actually, you're supposed to have only an closing click and not an opening click, but maybe the aortic was sclerosed. And of course, the looping is also not so accurate. But anyway, the LVOT VTI did appear increased, which is 43.4. Normally, you have it around 20. And then we measured the TAPSE, which was very much in range. And then we checked out the TR jet to measure the pulmonary artery systolic pressures. And then we also checked on to the IVC, which was 1.49 collapsing to 0.6. And then we did the E prime lateral, which was 7.12. The normal value is around 10. And when we did E by E prime lateral, it was 6.99. Okay, which typically means that the filling pressures are not raised. And when we did the E by E prime medial on tissue Doppler, it was around 8.41, which means the filling pressures are not raised. And this is something, S prime is something we take for the systolic function of the right ventricle, exactly in the way we do the TAPSE. Only thing is this is measured by tissue Doppler. And this was very much in a range, rather it was on the higher side. The normal value should be above 9. Then when we put the report together, we found that the LVOT VTI was grossly increased. Yes, one of the reasons is that it could be because of the presence of aortic valve sclerosis. Typically, we don't image them in these patients, and an improper waveform, but even then it was grossly increased. Stroke volume was grossly increased. Normally, it's around 40 to 70 ml. The cardiac output, which is a measure of stroke volume into heart rate. So stroke volume was 122 and heart rate was 105. So the cardiac output was almost 12 to 13 liters per minute. And the patient had a good contractility as we saw from eyeballing. Okay. Now we also found that in the mitral inflow, the E was less than A, which was suggestive of at least that the filling pressures are not raised, and E by E prime were both in the normal range, medial and lateral, which suggested that the filling pressures are not raised. So this patient had a hyperdynamic circulation and the filling pressures were not raised. Since E by A was 0.3, the patient had a grade 1 diastolic dysfunction. There was mild pulmonary hypertension. TAPSE was in range. So the final report when we write in the ICU is, it's a hyperdynamic LV systolic function. See the words, with grade 1 diastolic dysfunction and normal LV filling pressures. This is what the intensivist needs. Okay. Then we also have hyperdynamic RV systolic function because the S prime was extremely high with pulmonary hypertension. So this is what I need from the ICU point of view. There was a severely calcified and sclerosed aortic valve. Aortic valve area, which we checked later on, was 1.6 centimeters square per meter square. Okay. But then we had screened the patient because of dyspnea, and at the end of it, we know that this was not a cardiac dyspnea because the filling pressures were not raised. So if it was not a cardiac dyspnea, despite a setting of diabetes, hypertension, CKD, the filling pressures not being raised, then why was the patient dyspneic? Therefore, for further evaluation of dyspnea in these patients, we need a lung ultrasound, whether it's a primary or second pathology of the lung or it's a early ARDS. We need a venous Doppler to see whether it's a venous thromboembolism, and we need a ABG to see whether it's a metabolic acidosis which is producing this. So this is case 1. Now we move on to case 2. Oh, sorry, I'll just take time to screen share. Let's. No, I think I got the same case again. Just give me a minute. I'll change the case. So, just a second. Okay, so this is another case of sepsis with dyspnea. And this is again a sudden onset dyspnea in a setting of urosepsis. It's day 1. This patient had primary hypertension, diabetes, CKD. And again, as I said, these patients typically have LVH with a diastolic dysfunction and high filling pressures. Patient was not on ventilation. Patient was not on vasopressor. Okay. So here we see the plaques view, and in the plaques view, we see, if you look, compare it with the previous heart, this heart looks bigger. Okay, and it's good. It's still moving in. When I say contractility, it's moving in quite well. So definitely, I will say it's a dilated LV with good contractions. But whenever you give such a remarks, you have to confirm it in other views. In the plaques view, we took the LVOT diameter, and from the LVOT diameter, we took out the LVOT area. And then we went to the apical 4-chamber view, and we found again that the LV did appear dilated, and but the LVOT had, the LV was dilated, but the LV had good contractions, very good contractions despite being dilated. Then we went on to measure the mitral inflow, and we find here typically the E by ratio is 0.86. Again, I told you in any chronic patient, you will have generally the E by A ratio, which will be on the higher side, but here it was on the lesser side. Okay. Then there is another parameter we look at in the apical 4-chamber view, and that is the mitral inflow. We look at what is known as the intraventricular relaxation time. Basically, it is the end of aortic flow and the beginning of mitral flow. And this is a parameter which was okay. It was in range. As the heart becomes stiff, this IVRT increases, but it was very much in range. Then there are certain things we do in advanced echoes, but since it was done, we took the LA area. Okay, so all we have to do, we took the area, and then we, by the area length method, and this is how the LA area came. It came to 17.3 centimeters square. And then, of course, we took some measures across the right atrium and the right ventricle. I mean, those of you, when you read, you can understand this. I will not discuss this. And we took the TAPSE, which was 19 millimeters. And from the TR jet, we took out the pulmonary artery systolic pressure, which again appeared to be on the higher side. And this is a way by which you can add the right ventricular systolic pressures to the IVC, and from the IVC, you can derive the CVP. From the 5-chamber view, we took out the LVOT VTI, and this time the LVOT VTI was 27.8. The normal value is around 18 to 22. So this was very much on the higher side. Of course, here you can see that we are only having a closing click and we are not having an opening click. So this is definitely better than the previous patient. Then from the short axis view at the pulmonary valve level, we took out what is known as the RVOT VTI. And from this, we measure something known as the pulmonary acceleration time. I'm not discussing it here. And then from the subcostal view, we looked and we took out the IVC and found that the IVC was 1.37 collapsing to 0.5, and it was collapsing quite a bit. Okay, so this was a nicely collapsing IVC. And then we took out the E by E prime medial, which is 9.13, definitely very much in range. Then we took out the E by E prime lateral, which is 11.9, which is again very much in range. You don't have to do anything. As you keep saving, the machine will calculate your E by E prime lateral. It's 10.6, very much in range. Then this is how we put together a report. LVOT VTI is increased from the VTI by a formula. We calculate the stroke volume. You can also use online calculators. Stroke volume, so VTI should be around 20, it's increased. Stroke volume should be 40 to 70, it's increased. Cardiac output should be 4 to 7, it's increased. And of course, the EF by eyeballing also appears to be good. It can be even 55 to 65, it makes no difference. Okay, and on the other side, when you look at the parameters, you find that the E by E prime is very much here. If you look at it, the E by E prime medial is 13.9 and the E by E prime lateral is 10.6. So if you take the average 13.9 and 10.6 divided by 2, it comes to 12.25. So E by E prime 12.25. We'll see the inference in the next slide. And of course, E is less than A, so that itself produces what is known as grade 1 diastolic dysfunction. I mean, rest of the things are more or less in range. So what's my final report? My final report is hyperdynamic LV systolic function. There's no doubt on that because the stroke volume and cardiac output are increased. Grade 1 LV diastolic dysfunction. There is again no doubt on that because E is less than A. LV filling pressures elevated. Now, in much later in the discussion, I'll tell you. So typically, when you take out the average value of E by E prime, there are every author has given his own inference. But one of the formulas which is accepted is E by E prime plus 4.6 will give you the wedge pressures. So if you take 12.25 and if you add 4.6, that means it comes to 17. So the pulmonary capillary wedge pressure is 17. It can be, I'll say this is elevated for this patient. Mild pulmonary hypertension, normal RV function. So we have mentioned LV systolic function, we mentioned LV diastolic function, we mentioned LV filling pressures, we mentioned pulmonary hypertension, that's a finding, we mentioned a normal RV. Now you see this patient has come in with dyspnea. Filling pressures are raised, just slightly raised. So is he a candidate for diuretics? Well, maybe, but diuretics should be given under echo and lung ultrasound supervision. So if you're bolusing him with 10 mg Lasix or 20 mg Lasix, then in that case, you should do an echo and see that the E by E prime comes down. And you should also do a lung ultrasound to see that the B lines are reducing. Okay. Remember, if you give diuretics, it will bring down the filling pressures, but it may also worsen end organ perfusion because the LV stroke volume, okay, the LVOT VTI will also come down along with that. So therefore, don't be in a hurry to use a diuretic. Use diuretic only if desaturation is worsening or B lines is increasing. I mean, you need to be there at the bedside for some time and take a decision. Just for the purpose of discussion, if suppose the pressures are borderline, is this patient fluid responsive? Now, typically elevated filling pressures do not need fluids if cardiogenic. Okay, so if you have a cardiogenic pulmonary edema, definitely you will not give fluids. The correct way to check is you check the swings in the LVOT VTI. We saw the loop. Of course, that was not a proper loop. So we need to reduce the sweep speed and then attach the ECG and the respiratory electrodes and then check the swings in LVOT VTI, whether they are more than 10% or less than 10%. E by E prime is more than 14. That means it's elevated wedge. So what I have told you is one formula says if E by E prime is more than 14, the wedge pressures are high. The other formula says E by E prime, whatever the value, you add 4.46. Okay, and that is the wedge pressure. Okay, so here I can say that the wedge pressures are borderline elevated. And remember, giving fluids will increase the filling pressures, which he may not tolerate. So when you are stuck in borderline, or say you give Lasix 20 mg, and after that you find that, the patient becomes hypotensive and you give a small fluid bolus and you find again very quickly that the E by E prime will cross 14 and the patient may again go back into pulmonary edema. So these are some balancing acts which we need to do. Now, this was the second case, and we have seen now two cases which had a hyperdynamic LV. So now we'll see some cases which don't have a hyperdynamic LV. Just give me a second. Actually, I did not want to link all the slides together because the presentation becomes very big, and even if one video is corrupted, everything goes haywire. Okay, so we move on to the third case now, and this is a case of sepsis with shock and dyspnea. So again, what was the indication for an ICU echo? It was shock with dyspnea. The admitting diagnosis was acute gastroenteritis with septic shock. The scanning was done at admission. There were no comorbid illness. Patient was not on ventilation, but patient was on a low dose of noradrenaline, and with that the pressures were 106/56 with a pulse of 90. So this is the plaques view if you see here. Okay, and you can see a heart which looks good. It's of good size and it moves well. Okay, now typically when we examine these patients in septic shock, okay, in the clinical examination, and if we are expecting, a septic shock, it will be a warm shock. Okay, but then you need to differentiate between a patient whose sepsis is complicated by a primary septic shock versus a patient whose sepsis is complicated by a primary left heart failure. Okay, so remember that there are two different things. So if we put it under the heading of acute circulatory failure, which is shock, so we'll have to differentiate whether it is a distributive predominantly or whether it's a cardiogenic predominantly. So for a cardiogenic predominance, you will generally have a septic phenotype with a cool extremities, and the patient will have hemodynamic instabilities. There will not be a good response to vasopressors. There will not be a good response to fluid challenge. There will be arrhythmias. There may be an abnormal ECG. There will be a low SCVO2, and there will be an elevated troponins. Okay, vis-a-vis when you have a distributive shock, you will have warm extremities. The patient will respond well to vasopressors. Patient will respond very well to a fluid challenge. Arrhythmias will not be there unless you really give very high doses of noradrenaline or adrenaline, and the SCVO2 generally will be much better than this, and the troponins will not be elevated. These are some clinical tips. Same patient in apical 4-chamber view. Okay, and the most important striking thing you can find is that this heart looks much bigger than the previous two hearts. So if you look at the previous two, this heart looks much bigger. Definitely, I'll say it's dilated. And if you see the dilatation part, you know, you see the apex, which is supposed to be like a V, but here the apex is like a O. So this is definitely a dilated apex. Okay, so the mid cavity and the apex definitely appear to be dilated in this patient. And then, of course, we do the standard stuff. IVC is 1.6 and 1.08. LVOT diameter, the LVOT VTI. So here, when we take out the LVOT VTI, we find that the VTI is 23.8. So you look at the paradox, the heart is dilated, but it seems to be contracting well. And when you look at the LVOT VTI, that means the LVOT, which is a surrogate for LVOT stroke volume, it is good. So just because the heart is dilated doesn't mean that you don't give fluids or you give Lasix. Just take it out of your mind. And this is why we are doing this. Okay. One of the things you should remember is what I have written on the right side of the screen. Worse the shock, better the ejection fraction. And we will see it much later. Remember that the ejection, as the shock worsens, you know, as the distributive shock worsens, the afterload reduces, and therefore the ejection fraction appears to be higher. Okay. But it doesn't mean that the patient is doing well. Okay. So remember, whenever you get bad patients with good ejection fractions in shock, that means the shock is bad, or you get bad patients with, you know, good ejection fraction and increased LVOT VTI, again means the shock is bad, right? So this is something you have to remember. Then we look at the E by A, and in this case, you see the E. Finally, the E is more than A in this case. And of course, we look at the intraventricular relaxation time. I'll not discuss it here. We look at the TAPSE, and we find that the TAPSE is very much in range. It's 2.48. I mean, these are real-time loops. These loops were taken about 7 years back. So whatever best. So now if I look at this patient, remember it's a dilated heart. Stroke volume is in range. You can calculate all this by the calculators. Cardiac output is in range. Ejection fraction is good. Now, in a dilated heart, you know, still the ejection, the pumping is good. Okay, so the stroke volume, the cardiac output, the ejection fraction is good. And E by A is also good, very much in range. TAPSE is also good. And IVC is also very much in range. So this is a patient who is on a dilated heart and who's on a little bit of noradrenaline. So the final report will be normal LV systolic function with a normal stroke volume and cardiac output. This is how we write, because you can have normal systolic function with reduced stroke volume. All combinations can exist. A normal LV diastolic function, a normal RV function. But most important is there is no need to do fluid responsiveness as the LV stroke volume is in range. So from the heart, you make out the stroke volume is in range. From the ABG, you make out that the lactates are trending down. So you don't need to do anything. But in case the lactates are trending up, so you know that the stroke volume is in range. So the problem is not in the macro circulation. The macro circulation has been optimized. The problem is probably in the micro circulation or in the end organ, and you really need to look into that. There is no need to increase vasopressor as LV stroke volume is in range. Of course, if you find that the shock is worsening, you know, the lactates are increasing, the mean arterial pressures are falling, and your stroke volume is still in range, that is one of the reasons you may have to hike up, you will have to hike up the vasopressors. But again, so we had, it was a patient of shock with dyspnea. Okay, and what we found in the end was that it's a dilated heart, but despite the heart getting dilated, the filling pressures are not raised. So what is the cause of dyspnea in this patient? Definitely it's not related to the dilated heart. So the message from this case is don't be in a hurry to give Lasix. Do a lung ultrasound for ARDS and do a ABG for metabolic acidosis. Okay, so this was the third case where we finally saw a normal systolic function. Now we go on to the fourth case. Just a second, I've lost that screen window. So this is the fourth case, and this is here the indication is hypoxemia in a case of pneumonitis left lower lobe. Admitting diagnosis was community acquired pneumonia left lower lobe. It is day 2 post admission. There are no comorbidities. Patient is not on ventilation but patient is on supplemental oxygen and the patient is not on vasopressors. That is the basic which we need. And if we look at it here, again, you find that the LV, look at the LV. This is a proper optimized Plaques view. The LV again appears dilated, but there are good contractions. And by good contraction, it means that all the sides are trying to move in towards the center in systole. Again, we look at the apical 4-chamber view and you find that definitely the LV is dilated. Okay, but then there are good contractions. Just some flow. This is a 3-chamber view. Again, you find in this 3-chamber view that the LV is dilated. Okay, but the heart is definitely moving briskly. And then we look at the IVC and we find that ratio is 1.63 to 1.27. I'm not discussing all that. We look at the LVOT diameter. We look at the LVOT VTI. And we also look at the swings. This is not a classical image to discuss the swings, but I can tell you this is a 5-chamber view. We see the LVOT VTI and we see at a lower sweep speed. And we find that the VTI is 19.8 and the swings are less than 10%. I've calculated it on the machine, not from this. Then we look at E by A pattern and again we find that the E is less than A. And then we look at the TAPSE and we find it's borderline, it's 15 mm. And we look at the TR jet and we try to take out the pulmonary artery systolic pressures. Then we put the report together. So what is in blue is normal. So this patient, okay, this patient was having hypoxemia. Okay, and you find that the LVOT VTI is in range, stroke volume is in range, cardiac output is in range, the pumping is good. There's just grade 1 diastolic dysfunction. So the final report is that there is a normal LV systolic function with grade 1 diastolic dysfunction and normal filling pressures. And there is a mid and apical LV dilatation consistent with sepsis and a normal RV function. So despite the heart being dilated, despite there being a diastolic dysfunction, the filling pressures are not raised. So if the filling pressures are not raised, this dyspnea cannot be attributed to left heart failure. So can he have hypoxemia if the filling pressures are not raised? Definitely, you need to look into the lungs. The hypoxemia may be either because of a severe community-acquired pneumonia or an ARDS. So what you do a lung ultrasound, you check the B lines and you check for C pattern and you check for alveolar consolidation. Wait and watch. Okay, if the patient, so right now there's no need to give Lasix. Be cautious with fluids if the patient gets hypotensive, because if you're given fluids, the patient may suddenly have elevated filling pressures. And repeat the echo frequently to assess LV function and do a tissue Dopplers if possible. So for hypoxemia, your final answer is E by A and E by E prime. I'll just put it like that. And for hypotension, your final answer is the LVOT VTI. So you need to start doing this. This is the way you look at it. So we move on to the last case now. Again, a case of sepsis with hypoxemia. The patient had bilateral chest infiltrates on day 3 after admission for urosepsis. Comorbidities again were diabetes and hypertension. Patient was on NIV, IPAP 12, EPAP 6, FiO 2.5, but patient was not on any vasopressors. So again, let's look at the heart. Okay, so you can see a heart which is more dilated than all the hearts we saw. First, we saw 2 fast hearts. Then we saw 2 normal hearts. Now we see a slow heart. So this is big and slow. It's dilated, everybody will agree. And if you see the walls, they are not coming in as briskly. So definitely it's a dilated LV and the contractility is down. And if you look in the sepsis related myocardial depressants, there is a huge list. So remember, on top of it is cytokines. And the last thing you remember, the last line on the right side of the slide, there is myocardial edema due to capillary leak due to endothelial glycocalyx dropout. So if you know in sepsis, the endothelial glycocalyx sheds, there are produces leaky capillaries, that produces microvascular ischemia, and that produces myocardial edema. And that is the reasons troponins go up in sepsis related cardiac dysfunction. So there's a huge list. You can go through it later. Similarly, we see the same patient in the short axis view at the mitral valve level. And you can see that, you know, that circle is hardly coming in. In fact, the valve is moving much faster than the walls. The walls are just not coming in. And you should remember that, of course, the heart has become big and slowed down. And NT-proBNP and troponin elevation is definitely seen whenever sepsis affects the heart. It is not only a marker of LV dysfunction, it is also a marker of the severity of illness, which you can see by the SOFA score or the Apache score. But it's a most important, they are markers of increased mortality. So in a benign patient of sepsis who looks good, you know, but if you find that the troponins are elevated, be careful. These are patients who have twice the mortality than patients whose troponins are not elevated. And then we look at the short axis view at the papillary muscle level, and we find that again, it's a very, very poor contractility. Also remember that when you attach these patients to ECG leads, the patients where the heart is involved because of sepsis, typically you can see a sinus tachycardia. They're very prone to develop atrial fibrillation, but without traditional risk factors. So they may not be elderly, may not be hypertensive, may not be coronary artery disease. And for patients of sepsis with heart involvement who have fever, about 2% of them can develop a type 1 Brugada on the ECG. The reason it is important is that 2% to develop the type 1 Brugada, you have to be very careful, or sometimes it has a fatal outcome. This is the IVC. You can see here of all the IVCs which we have seen, it is the least collapsible. We see the LVOT VTI, and you know, till now we were 43, 28, 23, 19.8. You see the VTI here, it's 11.9. Okay, 11.9. It's half the normal VTI. And what I have done, all this cross and this dot and the square and the triangle, they are the LVOT VTI Vmax, which I have taken to see if the swings, you can take them as surrogate for swings instead of checking LVOT VTI in 5-6 loops. And even a LVOT VTI Vmax less than 10% is a good surrogate that the patient is not fluid responsive. Okay, so again, we've seen the LVOT VTI. Then we see the mitral inflow, and till now we were struggling with E less than A, and we had only one where the E was more than A. But if you see here, the E is 109 and the A is 44. E is twice A. Okay, E is twice A. And of course, TR jet. TAPSE is good, 1.6, very much in range. So now putting it all together, if you see the LVOT VTI is 11.9, much reduced. LV stroke volume, okay, is preserved. So the left heart is dilated. The ejection fraction is 30%. Okay, a dilated heart ejecting only 30%. But when you see the stroke volume, it is very much in range. And when you see the cardiac volume output, it is very much in range. So what has happened? What has happened is known as an adaptive dilatation. Okay, and it is good. And adaptive dilatation is a process where you have low contractility with preserved stroke volume and cardiac output. So suppose a heart has end diastolic volume of 100 ml and end systolic volume of say 30 ml. That means per beat, it shunts out about 70 ml. When this heart starts contracting poorly, very poorly, then the end diastolic volume will still be 100 ml, but the end systolic volume may be, instead of 30, it's going to be about 50 or 60 ml. That means per beat only 40 or 50 ml go out. Okay, so your EF anyway has dropped from 70 to about 50%, right? That is the normal setting. But what happens in sepsis is that the heart dilates. So if the septic patient came in and his heart was 100 ml and he was pumping out 60 ml and he was left with 40 ml, and that means his EF was 60%. Now what has happened? The heart is dilated. Therefore, the end diastolic volume from the 100 ml, I'll say, has moved to about, I'm just for the sake of explanation, I'm telling you, it has moved to about say 300 ml. Okay. But the ejection fraction is dropped to 30. So if he had an end diastolic volume of 100 ml and he was pumping out only about 30 ml and 70 ml was remaining behind, but he now has an end diastolic volume of 300 ml. So if he pumps out 30% of 300, it's going to be 90 ml and the rest will remain behind. So this adaptive dilatation of septic hearts sort of increases the end diastolic volume so that the stroke volume remains in range. That is one. And the compensatory sympathetic drive resulting in tachycardia increases the cardiac output, because cardiac output is stroke volume into heart rate. This is something you must remember. Of course, this patient had a dilated left atrium with interatrial septum bulging to the right. So left atrial pressures were high. E by A more than 2, it means that the left atrial pressures are high. If E by A is more than 2, it also means that the patient has got a grade 3 diastolic dysfunction. And good thing was that the patient's RV function was normal. So the final report is LV systolic dysfunction with normal stroke volume and normal cardiac output. The point to note is this patient is not a candidate for either a fluid challenge or a dobutamine. Okay, if the MAP is falling, then and the lactates are going up, then the patient may be a candidate for a vasopressor because of progressive vasodilatation, but definitely not a case for dobutamine. LV diastolic dysfunction with elevated left atrial pressures, no way you can give fluid to the patients. If he gets hypoxemic, you need to give him some diuretics without compromising the LV stroke volume and a normal RV function. So what happens if you use diuretics in these patients? It will reduce the raised left atrial pressure, but if you reduce the left atrial pressure, you may lower the left ventricular stroke volume. So remember that, if the patient is intricately balanced, some hypoxemia and just optimal perfusion, and if you given Lasix for the heck of it, Hypoxemia will improve, but stroke volume will come down. Therefore, one component of MAP is a stroke volume, and therefore the MAP will come down, and therefore the peripheral perfusion will go down. And when you give a vasopressor in this setting, so you brought down the MAP by reducing the stroke volume, and you go ahead and increase a vasopressor, it will increase the afterload, and it will bring down the stroke volume still further, and it will spoil your macro circulation. What happens if you increase the EPAP? It will raise the SpO2. Definitely it is better than giving diuretics, but it may distend the RV and spoil the hemodynamics if RV gets distended. And vasopressors, there are no role unless end organ hypoperfusion, as evident by raised lactates. So in these 5 cases, we have seen 2 hyperdynamic hearts, we've seen 2 normal hearts, and we've seen 1 hypodynamic heart. We've seen normal systolic functions, normal stroke volumes. We have seen reduced systolic functions with normal stroke volumes. Okay, we've seen normal filling pressures, and we've seen elevated filling pressures. Okay, and what we have not seen is right heart failure. So this is a lot of spectrum of sepsis which I had, and I could work on these slides and share with you. And now we'll go on to the last part of the presentation, which is generally putting it all together and understanding what sepsis and the heart is all about. Just a second. Can you see my screen?
Yes.
Yeah. Okay. So remember, it is a new movie in every round. Findings are very, very dynamic, and they change as per the round. It's not that what you've seen in the morning remains in the evening. So what are the variables I can calculate from echo? I can calculate almost all the pressures, and I can calculate fluid responsiveness in extravascular lung water. And how do I use these variables? Basically to decide whether the patient needs a diuretic or a fluid, inotrope, vasopressor, vasodilator, or a mechanical support. And also whether I need to optimize the ventilatory settings. So this is how we need. This was general. Now coming back to sepsis and the heart, we need to study both the LV and the RV systolic functions. How do we study the LV and the RV systolic functions? We look at the ejection fractions, and we can look at the ejection fractions by eyeballing, or we can look at the ejection fraction by what is known as modified Simpson's biplane method, where we take the end diastolic volumes and end systolic volumes. We take them in 4-chamber view, in 2-chamber view, as is in the images, and then we machine calculates end diastolic volume minus end systolic volume by end diastolic volume, and we get the ejection fraction. We can also do something known as the left ventricle fractional area change, and this fractional area change can be done in the short axis view at the papillary muscle level, where you can take the LV cavity in end diastole and end systole, and you can see the percentage of area change. For the right ventricle, one of the ways to study the function is right end diastolic area. That means in the apical 4-chamber view, you mark out the RV, mark out the LV, get the area, the machine will give you the areas and see the ratio. So typically it should be less than 0.6. So remember, sepsis has taught us one thing, that systolic function is not ejection fraction. Okay, so to study the systolic function, we can do ejection fraction. There are two methods for doing it. We can do fractional area change, and we can, for the right ventricle, we can do right ventricle to left ventricle and diastolic areas. Most of these are European things, so they are always asked in EDIC and EDEC both. Fractional area change and end diastolic area, they're very fond of it. So remember one thing, what sepsis has taught us is that EF is not contractility. EF is a balance between contractility, preload and afterload. So that means if you have a heart which is contracting, and if you give preload, that means you give volume to a certain extent, your EF will go up, after which it will not go up. And if you're using noradrenaline, and if you are using it inappropriately, that means you're using it at very higher doses than what is required, because the patient was fluid responsive, and instead of that, you've gone ahead and disproportionately gone up on noradrenaline, afterload will increase and therefore the EF will reduce. So this balance between contractility, preload and afterload is EF. And this concept is also known as ventriculo-arterial coupling. Again, a MCQ asked quite frequently. Okay, so we've seen EF, we've seen fractional area change, we've seen ratios of end diastolic areas. Now let's look at some other parameters. So the questions which are asked is, what are the shortcomings with EF? Shortcomings with EF, for the answer of MCQ is, it is dependent on the loading conditions, preload and afterload. So therefore, people looked at other things, like we look at TAPSE, somebody looked at MAPSE, and they found that MAPSE reflects cardiac contractility, but is affected by preload. And these are not so obsolete thing. I think it was written since the thesis from Bombay Hospital this year. Then somebody looked at S-wave. I showed you in the first slide the tissue Doppler of the right ventricle, exactly the place where we put the TAPSE. If you put it on the left ventricle, lateral wall, you get what is known as the S-wave of the lateral ventricle. Again, people found it reflects contractility but is affected by preload. So what sepsis has taught us is that EF is not a good marker of contractility. So people looked at MAPSE, people looked at S prime, but they still found that although not affected by afterload, it is affected by preload. So therefore, now people have moved on to what is known as global longitudinal strain or spectral tracking echo, which reflects only contractility and predicts mortality. So therefore, if you get a question, this is the cleanest marker for LV contractility is a global longitudinal strain. It picks up reduced contractility much early. It is not affected by loading conditions, and it predicts mortality very well. Okay, so if you look at the cartoon on the right, you see this is what we typically do: end diastolic volume and systolic volume. In global longitudinal strain, you take the longitudinal strain. This blue heart is in diastole. When it contracts, it becomes the red heart in systole, and therefore the global longitudinal strain is L1, small systole minus diastole divided by diastole. Therefore, you get this figure in negative. More negative the figure, the stronger is the heart. As simple as that. And then there is this beautiful paper which of I think 2003, which all of you should review, Hemodynamic Instability in Sepsis by Vion Baron, who came for our Eurasia. And if you look at this, in my entire talk, I kept talking about LV stroke volume and LV cardiac output. So remember, EF is not the best surrogate for contractility. Global longitudinal strain is a very good surrogate for contractility. But what matters to us is neither the GLS nor the EF. It is ultimately what is the stroke volume multiplied by heart rate, what is the cardiac output, because that is what goes out of the heart. And in this paper, they plotted from different studies. On the left side, if you see, it's the cardiac output, that means LV cardiac output. And on the right side, you have ejection fraction. And they found that there are many patients in septic shock where both the EF and the cardiac output is down, which is natural. But there are some patients who will have a normal EF, okay, who will have a normal EF, but despite having a normal EF, their cardiac output will be down. And there are some patients who will have a normal cardiac output, but their EF will be down. So, you know, you really have to plot. So for the patient in red, low EF, low cardiac output, I'll tell you what is to be done later. Is the management is different. For the patient in blue, high EF but low cardiac output, the management is different. And for the patient in green, high cardiac output but low EF, the management is different. At least try to understand this. Now moving on to diastolic function. So in critically ill ventilated patients, a septal E prime less than 8 is a marker for LV diastolic dysfunction. Okay, this is a very good paper by Paul Mayo, which says LV diastolic function by the intensivist. It is a no-nonsense paper, purely designed for ICU, very simple. That paper clearly brings out septal E prime less than 8 is LV diastolic dysfunction. And this other paper, again from Europe, brings out very clearly that septal E prime less than 8 is a strong predictor of mortality in septic shock after all adjustments. So remember, a low EF may or may not be bad. A very low EF is definitely bad. Okay, but diastolic dysfunction is really bad. Then we move on to the third thing, and that is the left atrial pressures. E by E prime more than 14, okay, is elevated left atrial pressure or left ventricular end diastolic pressure. This is very clear from Paul Mayo's paper, no nonsense paper on LV diastolic dysfunction by the intensivist. So E by E prime septum less than 8 is LV diastolic dysfunction. E by E prime more than 14 is elevated left atrial pressures or left ventricular end diastolic pressures. And from the other paper, it's very clear that this E by E prime more than 14 is a strong predictor of mortality in septic shock. And E by E prime plus 4.6 is equal to wedge. So the carry home message is for diastolic dysfunction, septal E prime less than 8. For elevated filling pressures, E by E prime more than 14. For calculation of wedge, E by E prime plus 4.6. And both diastolic dysfunction and elevated filling pressures are markers of mortality in septic shock. So this is a slide which is basically from echo-based hemodynamic monitoring. I'll just revise it here because it's important before we conclude. So if you are doing hemodynamic troubleshooting for the LV, if the patient is hypotensive, check LV stroke volume. If stroke volume is low, check fluid responsiveness. If fluid responsive, you give fluids. If contractility is low, start inotropes. If neither fluid responsive nor contractility is low, start vasopressor. Kindly remember these words. This is exactly how you get your type K questions and you goof up. Okay, so this is exactly the way it goes in real life also. If RV is dysfunctional, you've got a dilated RV, check whether there is pressure or volume overload or a contractility issue. If there is pressure overload, remove the causes of pressure overload. That means afterload for the RV is high. It could be high PEEP, high tidal volume, high intra-abdominal pressure, or a pulmonary embolism. If there is a volume overload, that means the preload is high, you give diuretics. Okay, and if the RV contractility is down, use a inopressor. Now this is typically a place where we don't use a inotrope. We prefer an inopressor as a temporary support measure. And remember, when the RV is dysfunctional, fluid responsiveness for LV is not reliable. Ventilatory troubleshooting, if the patient is hypoxemic, check left ventricle filling pressures by E by E prime and check extravascular lung water by B lines. If filling pressures are raised, give diuretics. If there is no response, try lung recruitment. For refractory hypoxemia, you look for shunt. You do a bubble contrast echo and see whether the bubbles move from right atrium to left atrium within 3 cardiac cycles. That is a intracardiac shunt, or after the 4th cardiac cycle, which is a extracardiac shunt, typically seen in hepatopulmonary syndromes. If hypercarbia is there, check RV function while decreasing the tidal volume and PEEP. right? So this is echo-based hemodynamic monitoring, troubleshooting, and this is what we do in sepsis also. Remember, you may have to do it more than 2 to 3 times in a day. So what are the learning points and carry home messages? There can be systolic or diastolic dysfunction of the left ventricle and or right ventricle. Left ventricle ejection fraction will be reduced in systolic dysfunction, but increased in hyperdynamic heart. But this ejection fraction changes generally do not result in changes of mitral inflow pattern. Left ventricle stroke volume may be preserved in systolic dysfunction by adaptive LV dilatation, thereby increasing the left ventricular end diastolic volume. Adaptive LV dilatation compensates if the patient is optimally volume loaded. Now you're saying, "Arey boss, heart is dilated, don't give volume, don't give volume." Then obviously, if the heart is dilating to protect the stroke volume, and if you are not giving volume to this patient, the dilated heart will be empty and the patient is going to crash. So therefore, in a dilated heart, if you have to give volume, so you will have to do your fluid responsiveness and then give the correct amount of volume. A cardiac output can be normal or it can be raised even with a low stroke volume if heart rate is increased. We have had patients where the LVOT VTI has gone to 6 and the heart rate has gone to 140. And then when you take out the stroke volume, it may be a little low, but when you check the cardiac output, it is bang on coming to 4.1, 4.2, just in range. And this is the time you have to stop some overzealous visitor from giving ivabradine to reduce the heart rate, saying otherwise the patient will get arrhythmias. No, it's not like that. And even when these patients have AF, you have to be very clear in reducing the heart rate so that you don't reduce it too much. So if a septic patient becomes hypotensive and the LVOT VTI drop and the heart rate increases, God is saving the patient. Please don't do a manual override of the process unless the patient clinically hypoperfuses or the lactates go up. LV dilatation does not carry a bad prognosis, a rare situation here. And this is a study which all of you must see, where in the emergency department, they compared the hemodynamic profiles of patients who came in with sepsis. Just look at the left lower part of the screen. 60% of patients were hypovolemic, 18% had left heart failure, 30% had hyperdynamic LV associated with vasoplasia. That means greater the degree of vasodilatation, more hyperdynamic will be your LV. More hyperdynamic the LV, the more volume it will need to keep its chambers filled up adequately. 13% had right heart failure. So typically hypovolemia still remains the most common profile you see when you scan the patients of sepsis and septic shock. This is another paper all of you must read in your free time. And what they did was, this is of course artificial intelligence. They took 360 patients where TE was done within 12 hours of septic shock. All patients were sedated, paralyzed, and on ventilation. And they found that these patients of septic shock typically fall into 5 clusters on echo. So one cluster is, if you look at the black here, well resuscitated, no LV or RV dysfunction and not fluid responsive, 16%. Okay, another cluster is LV systolic dysfunction, 17%. Hyperkinetic profile, 23%. RV failure, 22%. Hypovolemia. So at the end of doing an echo, on a septic patient, you should make out your patient is fitting into which profile, because mortality is dependent on this. If you have a LV systolic dysfunction, ICU mortality is 50%. If you have a RV failure, ICU mortality is 42%. If you have uncorrected hypovolemia, the mortality is 40%. Hyperkinetic profile, 23%. And the best patients still have a mortality of 21%. So, your answer should be, my patient is falling into which subset. And for these subsets, which are the parameters they use? For left heart failure, they found ejection fraction less than 40% and VTI less than 14, fractional area change less than 33. For right heart failure, they found RV to LV EDA more than 0.8. And of course, blood pressures I am not discussing. Hypovolemia, they found that the VTI was less than 16, EVA was less than 67. We are not going, but most important thing which they ask in exams is SVC collapsibility. So for the purpose of EDIC, left heart failure is a low LVOT VTI and a low left ventricle fractional area change. For the purpose of EDIC, right heart failure is RV to LV EDA more than 0.8. For the purpose of EDIC, hypovolemia is a superior vena cava collapsibility of more than 36%. These are all patients who are sedated and paralyzed on ventilator. And hyperkinesia is again a VTI of more than 20 and a fractional area change of more than 58%. See, you know, this is how these Europeans work. These are certain things they expect. So when in your type A and type K, you should know exactly what to answer. So continuing with the learning points, diastolic dysfunction with a raised LV EDP carries a bad prognosis. The picture may change over a few hours. Do not get obsessed with EF. We have seen echoes being done in the morning, EF 60%, and patient is dead in the evening. RV dysfunction does occur and should be considered in refractory shock. So if you find a good LV and if you find everything is good, but the map is not coming up, think of RV. RV dysfunction plays spoil sport as dynamic indices of fluid responsiveness cannot be used and it reduces a 1-year survival. Do not produce a dynamic LVOT obstruction by inappropriate inotrope dose on a small LV cavity in a setting of tachycardia. So this is I'll say a LVOT VTI where you find that the LVOT gradients, you know, they are this is in meters per second. They should be around they should be less than 1 meter per second. They should be about 70 here, and they are almost 6 meters per second. So typically what happens is patient is on actually the patient is a dilated LV and the patient is fluid responsive, or the patient has a small LV cavity. Patient is typically a hypertensive patient and or a asymmetric septal hypertrophy or a LV and this is volume responsive. LV cavity is small, but instead of giving volume, you're pushing in adre, noradre, dobutamine, and the more you increase the dobutamine, the more the pressures fall and the gradients are there. Basically, you are choking the LVOT, and that is why the gradients are becoming bigger. Stop the dobut, reduce the norad, and kindly give in lots of fluids, and you will find it opens up and the gradients stop. So this is known as dynamic LVOT obstruction. It is again asked very frequently. It's one of the complications of bad fluid therapy, not giving fluids and giving a inotrope where fluid is required, and it's typically reported by Michel Slama, I think 20% of patients of sepsis. So septic cardiomyopathy or sepsis involvement of the heart is reversible. Spectral tracking echo is used for early diagnosis and predicting mortality. So it's the same machine. The machine has a mode known as spectral tracking. You acquire the images by the same probe in the same way. And then of course you press 1 or 2 buttons and it does. The rest of the thing is done offline. What is the differential diagnosis of sepsis involvement of the heart? It's important to discuss. One is sepsis related Takotsubo. Maybe sometime later, after a couple of months, we will discuss Takotsubo. Acute coronary syndrome. See elevated troponins and abnormal ECG. Even in the setting of sepsis, the cardiologist will scream it is sepsis, 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 but always write that one line of intensivist, rule out coronary artery disease subsequently. Third differential is dynamic LVOT obstruction with systolic anterior motion of the mitral valve and intracavitary gradients and a pericardial effusion. Aortic dissection. And these are my carry home messages. So on the left top, you have a proposed diagnostic criteria for sepsis-induced cardiomyopathy. I think we've covered most of these things. Remember, they are only proposed. On the left bottom, you have risk factors, young male, high severity of illness, diabetes, and pre-existing heart failure. What is very clear, it occurs more commonly in patients with pre-existing heart failure. On the right top, we have a thing that, just a second, we have this. A recent database study suggested among patients with sepsis, echo assessment of myocardium influenced hemodynamic management, liberated patients from vasopressors earlier and decreased 28-day mortality. So if you follow, I will say in a nice way, my lecture, and if you do what I have shown you is to be done, okay, it will result in patients getting liberated from vasopressors much early and a decreased 28-day mortality. Then in the left down, you see there are two things. Extreme right, it is spectral tracking echo, which tells you that on global longitudinal strain, if the contractility is reduced, they are non-survivors. And the one in the center tells you that on global longitudinal strain of the right ventricle, if the contractility is reduced, the odds ratio of dying are almost 26 times. So, patients who can afford it, who look more bad than what they are supposed to be, and echo primi facie seems borderline. Ask your cardiologist to do spectral tracking of the LV and the RV free wall. They're very early pickups for sepsis-induced myocardial dysfunction, and you can actually prognosticate very well. So I have put together all the loops you saw were when me, Akhilesh, and Gunadhar worked together long back, I think between 2014 and 16. And that's why some of the loops, I was also on a learning curve. And the rest of the things I have put together from my experience of EDIC and EDEC and all the concepts. There's a beautiful lecture by Daniel DeBaker on sepsis-induced myocardial dysfunction. I have some screenshots of it. And if you have any doubts, you are free to ask, and we can also be in touch subsequently. Thank you.
Oh, wow, thank you. Thank you, Dr. Vivek. It was indeed a very informative session. And I think we will not be able to get this information in the textbooks as well. And I think we are really blessed today to have you with us.
Some information is not put in textbooks so that Indians come and take the exam and they fail. Otherwise, who will give the money for these European boards? So you have to remember a lot of things. So, but the nice thing is that they will fail you till the time you start thinking and working their way.
Yeah.
So, I mean, I'm not blaming them. It's of course money making, but till the time they change your mindset, So I think if you look at it, it's a change of mindset for me also, and to understand how to manage sepsis echo-based.
Today, echocardiography is really far beyond what we really think from the cardiologist perspective. From the intensivist perspective, it is far, far different. I think we really need to learn more on this today echocardiogram. Really, it is an eye-opener for us, and we will take a good message. There are a few questions on this. I mean, what is the best way to method LV filling pressure? Somebody has asked this question. What will be your opinion, Dr. Vivek? Yeah.
So there is only one opinion, and that is E by E prime. So all your machines have tissue Doppler. Just in case your machine doesn't have a tissue Doppler button, so what you do, you put the pulse wave Doppler on the mitral annulus, medial annulus and lateral annulus, and the velocity scale. Like I always say, if you are looking at mitral inflow velocity, it will be 50, 60, 70, 80 centimeters per second. But when you take the same damn pulse wave Doppler and you put it on the mitral annulus, medial and lateral, just change the scale to 10 to 15 centimeters per second, because tissue moves much lesser than blood. And then even if you don't have a tissue Doppler, your pulse wave Doppler will act like a tissue Doppler, because tissue Doppler is only a button. Like on microwave, it says fish fry, you press fish fry. Here you don't press fish fry, you just reduce the scale and you will get the tissue velocities also. Okay.
Yeah. So Gunadhar, your phone is not muted. Yeah.
Okay.
Okay,
I'll just see the questions if there are.
Yeah. So there are a few questions.
Okay.
I mean, people have written excellent presentation. People have really liked this presentation. Probably it's an eye opener. Someone has already quoted that it is an eye opener. Really.
So one question is, in the first 3 cases, all patients had acute dyspnea but had good SpO2. How do we explain? So that's what I said. We did the echo and said that the dyspnea is not because of elevated filling pressures. In one case, it was because of elevated filling pressures. So if the dyspnea is not because of elevated filling pressures, that means it is not because of the heart. So it could be because of a lung, by something known as the primary lung pathology, like a community acquired pneumonia, which is getting bilateral and severe. Or it could be a ARDS, which is producing leaky capillaries and the B lines are increasing. Okay. Then if the LV filling pressures are high, should not the patient have restrictive diastolic filling pressures? Well, the LV filling pressures can be high. Definitely, if the E by A is more than 2, which is known as a restrictive diastolic filling pressures, then there is no doubt that the LV filling pressures are high. But if the E by A is still not more than 2, I'll say the E by A is only 1.6, 1.4. You need to do a E by E prime, because if the E by E prime is raised, then the LV filling pressures are raised. So remember that diastolic dysfunction in the intensive care unit, as I will just say very crudely, as the number of days in the ICU increase and the patient becomes susceptible to nosocomial infections, similarly, as the number of days of ICU increase, you can just presume that the LV becomes more stiff. Diastolic dysfunction is only one cause of elevated left ventricular filling pressures, which is typically the domain of the cardiologist. In the intensive care unit, if the patient has come with a grade 1 diastolic dysfunction as sepsis and ARDS functions, you will find that grade 1 diastolic dysfunction has become grade 2 or 3 diastolic dysfunction. That may be the case. But if you look at an algorithm of elevated filling pressures in the intensive care unit, the algorithm is very clear. 1, is there LV systolic dysfunction? Yes, use diuretics. No. Is there LV diastolic dysfunction? Yes, use diuretics. No. Is there acute valvular regurgitation like a bad MR and AR? Yes, tackle that. No. Is it a state of chronic fluid overload like a renal failure and organ failure? So remember, your question is correct, but in ICU, there are many more causes of elevated LV filling pressures other than diastolic dysfunction. So remember, systolic dysfunction, diastolic dysfunction, valve regurgitation, fluid overload. Okay, so you have to tackle them one by one.
Yeah. Hi, Dr. Vivek. I think I must congratulate you. This is one of the excellent
Fantastic.
questions.
Fantastic. I mean, there is no words to express.
No, it is not fantastic. I will say this is the way we have been fooled. And it took so many years. See, all these loops were taken when we worked together. So to unfool myself and understand, after passing EDIC, I had to do EDEC, and that too for 5 years to get all this nonsense sorted out. So this is the correct way they expect you to work. They expect you to answer type A, type K, and work in the intensive care unit. One paper I strongly suggest is read Hemodynamic Instability in Sepsis, Barrow 2003. Remember, nothing has changed in 20 years after that paper.
So the thing is that most of our intensive care trainee who are just newly learning the echocardiography. So basically for them, it is a very much challenge, like how to assess whether the patient needs fluid or whether the patient needs vasopressors or whether the patient needs inotropes. So just there are 1 or 2 questions is there any simple methods or any checklist they can perform, like 1, 2, 3, 4, 5, by which they can quickly assess all these 3 aspects of the the patient management? That will be easier for them.
I'll tell you so in all the 5 cases I showed only the checklist. So the first thing is, remember, certain things you have to do is first learn how to take the LVOT VTI. Second is learn how to take the mitral E and A, and third is to take out the tissue Doppler E by E prime. That is it. So if you have a LVOT, suppose you have a LVOT VTI which is less than 18, then you know stroke volume is reduced. So if your stroke volume is reduced, okay, that means either the preload is reduced or the contractility is reduced or the afterload is high. So if the preload is reduced, you will have to see whether the patient is fluid responsiveness. Again, in fluid responsiveness, you have to see the LVOT VTI swings, which we will discuss separately. We can't discuss it here, but you have to go to the LVOT VTI, reduce the sweep speed, see the swings. If the swings in LVOT VTI are more than 10%, you presume that this patient is fluid responsive and you give fluids. If you give fluids and if you find that the LV stroke volume is increasing, that means this patient is fluid responsive. So what is fluid responsive? It basically means that when you give fluids, the LV stroke volume or the cardiac output increases by at least 10%. Okay, that is one. Now you find that LVOT VTI is reduced, but there are swings are less than 10%. Okay, like LVOT VTI 18, 19, 17, 16, the swings are less than 10%. So then you look at the contractility, and for contractility, you have to look at, crudely we look at eyeballing EF, but you can do modified Simpsons, and you can look at fractional area change. Of course, we don't have spectral tracking in our machines. You look at if the contractility is low, then you need to increase the contractility to see if this can result in an increased stroke volume. And here typically you give some dobutamine and C. Europeans are very fond of doing what is known as a dobutamine stress challenge also, and they give dobutamine to see if these slow moving hearts can move faster. But remember that dobutamine is a dilator, so it may improve your stroke volume, but it may drop the map because there'll be peripheral vasodilatation. And if you find that no boss, this is not there, then sometimes just come down on the dose of noradrenaline, you reduce the afterload, and the EF will come up. So this is the way of optimizing the LV stroke volume, or I will say the surrogate for stroke volume, and it is a monitoring of the forward function of the heart. If you look at E by A and E by E prime, all you have to do is E by E prime is more than 14. That means the filling pressures are raised. Then you give diuretics, but don't bring down E by E prime to the extent that your LV stroke volume falls. So I think learn three things: E by A, E by E prime, and LVOT VTI. But you have to learn to acquire the correct image, and after that you learn at least these three things and go very objectively, plot these three things, and and over some time you will become comfortable. And there are online calculators which will give you all the values also. So we'll have I'm planning a workshop maybe this month end, and if it is there, it will be very close to you, Apollo Hospital, and I'll let you know.
Sure. And what is the role of here the IVC? Most of the times our training, they used to see the IVC diameter, and they determine about whether it is a congested heart, it means congested circulation, or the patient is fluid responsive. So what is the relation? Any your take on this?
So see, IVC generally is not the best marker for fluid responsiveness. In fact, IVC collapsibility is generally not a good marker. So for any purpose, if the patient is a spontaneously breathing patient, and if the patient doesn't have any condition like acute exacerbation of asthma, COPD, severe pain abdomen, whereby he is tachypnic for some other reason, okay, in this case, if you find a IVC which is small and collapsing, you can give fluids empirically. On the other hand, whatever the patient, especially chronic patients, if the IVC is big and non-collapsing. So if the IVC is less than 1 centimeter and collapsing, and the patient doesn't have asthma, COPD, pain abdomen, or any other cause of acute dyspnea, including anxiety, that means the patient probably can tolerate fluids. If the IVC is more than 2 centimeters and there is a loss of respiratory waveform, in this case, the patient generally will not tolerate fluids. So this is for a spontaneously breathing patient who has just presented to the emergency or to the intensive care unit. In mechanically ventilated, sedated, and paralyzed patients, it is just the opposite. If the IVC is distending more than 20%, okay, in inspiration, that means this patient is volume responsive and the patient will need volume. Okay, so you have to see the setting: spontaneously breathing, sedated, and paralyzed. In spontaneously breathing patients, even if I start breathing very fast and hyperventilating, my IVC will start collapsing. It may not be small and collapsing, but definitely it will be collapsing more than 50%. So a small and collapsing IVC in a spontaneously breathing patient, in the absence of confounders, give volume, and a big and non-collapsing IVC in a spontaneously breathing patient, do not give volume. And here the confounders are bad NIV. You put EPAP of 10, obviously the IVC will distend. Okay. And I remember IVC does not work with right heart failure. It does not work with pericardial effusion. It does not work with ascites. It does not work with a bad NIV. And it does not work with bad ventilation. That means non-lung protective ventilation.
Absolutely. And if you have a facility for cardiac output monitor and you have a facility for echo, so how both these things are complementary to each other, and they can basically
determine. So again, this is a very good question, and it took me many years to realize this. So just to put it in a, say, a type A question, it is like this, that you need a change in cardiac output of at least 10% to be picked up by echo. Okay. So the cardiac output has to change by at least 10% to be picked up by echo. But if you put a advanced hemodynamic monitoring gadget like your Vigilio 1000, you need a change in cardiac output of just 3% to be picked up by the advanced hemodynamic monitoring gadget. So therefore, when we do passive leg raising, and if I'm using an echo, there should be a 10% change in cardiac output. And that is why studies of passive leg raising using an echo are different from passive leg raising using a advanced hemodynamic monitoring gadget. But typically, if you look at end expiratory occlusion, that is one. And I think the other study was tidal volume challenge. They have been done using advanced hemodynamic monitoring gadgets, if I'm not wrong. So you can pick up changes in cardiac output of almost 5%. So advanced hemodynamic monitoring gadget is more sensitive to changes in stroke volume and cardiac output as compared to echocardiography.
There are situations where we find that LVOT VTI index calculation is sometimes maybe erroneous as well, especially in case of a valvular pathology, aortic valvular pathology, or some septal issues, or there is hypertrophy of the myocardium, or sometimes the view is not good enough. So what would be the best way to assess fluid responsiveness in that situation? That is one question. Second, if I'm not able to visualize LVOT VTI in my usual plaques view or any other views, so what would be the best window to get a good calculation of LVOT VTI?
If you cannot visualize the LVOT VTI in apical 5-chamber view, in the short axis view at the pulmonary valve, you go for the RVOT VTI.
Okay, so pulmonary view will be very
It's a very good surrogate for LVOT VTI. There is no difference in the interpretation. Second, if you have a problem with aortic valve or some other problem, you just do the serial LVOT VTIs. Okay. You will at least know whether it is increasing or decreasing.
So third,
typically when patients of aortic valve stenosis come to the intensive care unit, and if you see, it will be written a tight aortic stenosis, mean gradient across the aortic valve, 20 millimeters of mercury. Now, when you are doing the echo in the ICU, you find, boss, that the mean gradient across the aortic valve is only about 10 millimeters of mercury. So why the hell has the mean gradient across the aortic valve fallen? Because this patient has lost volume, he needs volume. You give him the volume that the mean gradient is going to increase. So always compare the last echo report with what you are doing. If the E wave height has reduced, if the aortic valve gradients have reduced, then you know that it has reduced because the patient is hypovolemic. You give volume and it will come up.
Same holds true for aortic regurgitation also. There also we'll have to see the trends. We'll have to see the trends.
In every patient, see the trend of E by A, E by E prime, and LV stroke volume. It will be written very clearly. If you have a severe MR, tissue Doppler does not work. But I'm asking you, you see the trends. We are not here to give a report to do MVR. We are here just to see the trend. So today, if your patient has come in with acute MR, and if I am finding that the E by E prime is say 21, okay, it doesn't mean that you give him Lasix and all. It is 21 because of the MR. But in the night, if the patient has a GI bleed, next day you will find that the E by E prime has come to 14. So that's what I'm trying to say. You should do everything like a robo. You come and you do your stuff and you keep plotting it, and then you check why the hell has this dropped, why the hell has this increased, and you will learn hemodynamics.
Absolutely. And what about the relationship of PA pressure in assessing the fluid with echo, means compared to echo by Dr. Sakuntala to Dr. Vivek?
So see, I've told you that filling pressures are E by A more than E by E prime plus 4.6 will give you the pulmonary capillary wedge pressures. Okay, so that will give you the wedge pressures, but that is a static measure. It is like a CVP value. Like CVP gives you the pressures of right side of heart, the wedge gives you pressures of the left side of the heart. it can tell you a state of chronic fluid overloading, but you cannot use it for fluid responsiveness. There are two different things. So if my if my E by E prime is high, I know that this patient has got high filling pressures. He is not a candidate for fluids. But then I cannot say that just because E by E prime, I cannot use it for fluid responsiveness. I can just use it as a static measure.
So most of the times, the PA diastolic pressure usually mostly correlate with the sometimes the left atrial filling pressures, and that's a very good surrogate marker. In mostly the cardiac ICU setups, we used to measure this PA atrial diastolic pressure sometimes to give fluid, particularly in the cardiac surgical patients. But
Yes,
otherwise, you right.
if you find that there is hypotension in the PA pressure, you give fluids. So what I'm trying to say is, there are two things. One is fluid responsiveness and one is the fluid status. So definitely if your E by E prime is high, that means your wedge is also high. That means your PA diastolic is also high. So they are not candidates for fluids. And if they are low, then I will not tell you to give fluid on the basis of low E by E prime. Yes, if you have a swan, you can give it on the basis of a low PA diastolic pressure or a low wedge over there. But in echo, we don't use it for fluid responsiveness. We don't use E by E prime for fluid responsiveness. Rather, the concept now is that if your CVP is high on a central line, and if your wedge is high on a swan, and on an echo, if your CVP is high based on interpretation from IVC, and if your E by E prime is high, that means this patient is congested. And if he's running into multi-organ function more than hypotension, the bigger worry is congestion, and this guy needs to be decongested, especially the right heart and the left heart. Otherwise, the liver, the kidney function, and the intestinal function will worsen because of congestive hepatopathy, nephropathy, and intestinopathy, and these organ functions will decline. So CVP and wedge are very good markers for the chronic fluid status of the patient. So it's like, but they are not good markers for fluid responsiveness. So if a patient is crossing day 3, day 4 in the ICU, and you find the CVP was 11, 12, 13, 14, that means this patient is going into congestion and he will have congestive organ failures, which is worse than hypotensive organ failures.
Absolutely, absolutely. And my another question is like role of echo in the weaning of the patients. So most of the times during weaning, we find there is RV dysfunction, and sometimes the patient is difficult to wean.
Yeah, so it's again, I'll tell you just simple things. One of the biggest causes of failure of weaning is weaning associated pulmonary edema. So all you have to do is, when your patient is on a weaning, say patient is come on a pressure support, you can sort of take the very simple E by E prime. So if your patient is on, say, PS of 6 and a PEEP of 4, FiO2 of 0.3, ready for a SBT, and you do the E by E prime, and you find that it is around 12, and then you bring down the PS to 2 above PEEP, or you can take the patient on a TPs, and then you find that the E by E prime is shooting up to 14, 15, 16. This patient will go into weaning associated pulmonary edema. You need to dry up the patient more because the filling pressures are high. So you need to give some diuretics and then wean him off slowly. So for weaning associated pulmonary edema, you do the E by E prime on your spontaneously breathing mode like a pressure support. You can come down on the degree of pressure support 6, 5, 4, 3, 2. So if you have a PS of 2 above a PEEP of 4, is good. That means you're taking care of it's like as good as a TP's trial. It's a PS, it's a weaning trial, it's a spontaneous breathing trial on pressure support. And if you find that as you reduce the pressure support, the E by E prime value is increasing, that means this patient needs to be dried up more.
If you try this patient, probably we may not need NIV post extubation as well. Yeah, we can avoid NIVs. Usually,
got many reasons. He could be frail, he could be elderly, and he may not have the muscle capacity. But in acutely, he is going to fail your spontaneous breathing trial.
So, do you find any advantage of TE over the conventional 2D echo in your clinical practice? Or
See, there is
And then-
in my practice, I am reasonably good. So it is I can manage with a transthoracic. But then if Toyota comes out with a new model, so you got to at least know the new model. So TEs come into the curriculum, and when these people bring something into the curriculum, they bring it into the MCQs, and you start losing marks unless you master it. But I'll say we have very good simulators in Mumbai, so you don't have to worry. At least you can learn the basics of T's so that you can clear your MCQs.
Yeah.
And if
Where
you are
the
in a
role-
cardiac surgical unit, then you can. And other reason we need to learn TE is because most of our centers have now become ECMO and transplant enabled. And you have to remember that you don't have a person sitting there round the clock. So if you need a TE at a time when the cardiac surgeon is operating another case and his anesthetist is busy, he will ask the intensivist to do the TE.
right.
And so on the mill, right? It's not like olden times. No, intensivist cannot do TE. No.
Right.
No.
So there are two scenarios by Dr. Arnab. One is in the refractory septic shock. So he wanted to know which is the preferred vasopressor after NORAD, vasopressin, and adrenaline. And the other question is like echo in a setting of post-transplant RV failure and severe PH. So just a summary.
There is no vasopressor after noradrenaline, vasopressin, and adrenaline. That means we are missing the cause. One. Second is check again whether the patient is fluid responsive. Check if there is something which is producing refractoriness to catecholamines, like a severe metabolic acidosis or a gross hypocalcemia. I think I will and look at the cause again. Okay, and you could be having anything. You could be having an ongoing bleed, or you could be having. So you will have to again do the E by E prime. So if your E by E prime is low in I will say in a refractory hypovolemia, I'll ask you to give fluids. Second is you'll have to look at the LV stroke volume. If your LV stroke volume is low despite 3 vasopressors, I'll ask you to check fluid responsiveness and contractility and go up on the vasopressor if it is not there. And third, I will ask you to look for LVOT or intracavity gradients to rule out a dynamic LVOT obstruction. Then for post-transplant pH, anything on ECMO and post-transplant, I'll tell you needs 2 to 3 echoes a day by 1 or 2 operators. As simple as that. Because once you're doing it serially, you will pick up things.
In a post-heart transplant,
average,
probably serial monitoring of TAPSE will be more reliable.
TAPSE, anything. TAPSE is S prime. You have to look. You see, generally morning rounds you'll put the probe. There will be at least 2 events in the day in every post-transplant patient. So 3 transthoracics will be done. But yes, eyeballing, TAPSE, S prime, they're good enough.
Correct.
Is there any role of monitoring of SPC collapsibility index? What is the stand in the present scenario?
No.
As far as fluid responsiveness is concerned.
This is discussed.
It is one of the gold standards for monitoring fluid responsiveness in a patient who's sedated, paralyzed on a mechanical ventilator. It was first described by Viaboro, and it is standard. It is type A, type K, VIVA, everywhere. If you don't say SVC more than 36% collapsibility, you cannot pass any of these exams. So please read the paper Hemodynamic Instability in Sepsis by A.V. Barrow, 2003. Just Google it. It's free. Read it. Okay. And come back with questions you can put the questions to Gunadhar. He'll send it to me.
Yes. So this is not a question. Basically, this is a compliment by Dr. Satish Kumar. So thanks a lot. Would like to hear more lecture from Dr. Vivek. So if he is available.
Hi, Doctor. Hi, this is Dr. Subhadeep here.
Yes, Subhadeep.
Hi, sir. How are you, sir? There's a very interesting talk that you have.
Yeah, continue, Subhadeep.
Hello.
Yes.
Can I hear?
Please.
Okay. No, it's a very interesting talk that you have described in a very lucid way of when to give vasopressors, when to give fluids, when to give inotropes, and that is extremely important for probably each and every intensivist, whoever is working in the ICU. So first of all, that is very nice. Thing is that we also do the lots of echo in our ICU. We try to, anybody on a septic patient, we try to understand the systolic function of those patients, diastolic function of those patients. My question, or basically, I just need to understand from your thoughts perspective. Like in current scenario, there are a lot of changes in the definition of septic cardiomyopathy is going on. So previously, whenever we need to label somebody who is having septic cardiomyopathy, we need to see the EF. If the EF is less, then we need to label is a kind of septic cardiomyopathy. Now we are seeing lots of diastolic dysfunction also happening in the septic patients, and they also come in the category of the septic cardiomyopathy. But there are a lot of pitfalls in labeling somebody, especially somebody in the elderly hypertensive who becomes septic.
Yeah.
They
So
may be a pre-existing diastolic dysfunction probably.
yeah.
Some amount of grade 1, grade 2
I've got your
diastolic
question.
dysfunction.
So if you see, my talk is sepsis and the heart.
Yes.
I personally do not agree that there is something known as septic cardiomyopathy, right? That
Okay.
is why I just put in those proposed criteria, because there are students sitting here who are supposed to know.
Yeah, that has come probably
Remember,
some 2 years back
so,
probably.
like whether you have a patient of COPD who comes into ICU, pancreatitis who comes into ICU, COVID-19 who comes into ICU, you have a patient of sepsis coming into the ICU, scan him every day, do the E by A, E prime, and LVOT, VTI, and that is it. So if suppose this patient is a CKD, LVH, grade 3 diastolic dysfunction, and if he comes in into your ICU with a bad community acquired pneumonia, you will find that his last report 2 weeks back, echo had said concentric LVH, grade 3 diastolic dysfunction, E by A 2.5 and E by E prime 18, and say he was on a maintenance hemodialysis. But when this patient comes to the intensive care unit and you do the echo, you will find that the E by A is 1.8 instead of 2.5. The E by E prime from 18 has come to 11. Of course, the E prime, which was say 6.5, will remain 6.5 only, and that will not change. That is the beauty of E prime. And you will find that the LVOT VTI, which is not done on an OPD basis, but you will find that suddenly it's around 16 or 17. So I am very clear, and that is why I have put the heading as sepsis in the heart. There is nothing called septic cardiomyopathy. There is definitely something known as sepsis related myocardial depression. There is something that you have to differentiate a septic shock, which is a distributive shock, from a sepsis related myocardial dysfunction. You have to agree that both can exist. So what you do, take the last echo report of the patient and you keep plotting. So if your E by A has gone down, that means volume has gone down. If your E by E prime has gone down, that means filling pressures have gone down. Filling pressures can go down either when mostly when the volume goes up or when the contractility increases. That cannot increase unless you have put jabardasti ka dobutamine on the patient. And LVOT VTI you can follow. If it goes down, that means you have to look whether the patient has a GI bleed or a third spacing or a low contractility. So no definitions, plot it every day, plot it on an Excel sheet for one patient, and you will learn more than what books teach you. So don't give definitions to septic patients. You do the standard echo-based hemodynamic monitoring and you treat based on your monitoring.
So I think practice is the key here actually. The more and more you practice, I think it will be much more easier for a practicing intensivist. And
So
similar
after-
like uremic cardiomyopathy, it may be like something, it can be, it be excluded anyway from the sepsis cardiomyopathy, or you have the same
No,
finding.
see, I'll tell you, unless a patient has a label of a dilated cardiomyopathy and comes into the intensive care unit, or the patient has a label of a restrictive cardiomyopathy or a hypertrophic obstructive cardiomyopathy, let us not define any cardiomyopathies. Any cardiac abnormality in ICU, there is no point calling it a cardiomyopathy. And if you find the word cardiomyopathy, you take out the person who has described it, you will find that mostly this doctor is from a non-English speaking country. Okay. So if you learn French, then everything will be zhoo, zhoo, zhoo. So it doesn't go like that. So let's not give labels. It's very confusing and the labels lead to wrong. They give their wrong connotations to the patient. So if the patient is uremic, I told you, he will have LVH, he will have a mild pericardial effusion. He will have grade 2 or 3 diastolic dysfunction. He will have an elevated E by E prime. ये तो होगा ही होगा. Even if he doesn't have an echo report, you can presume this. And then he comes into the ICU. Suppose this patient has an acute MI and he comes. So then you will find that the EF has dropped and you will find that the E by E prime has gone up and you will find that the grade of diastolic dysfunction has worsened. But if he has a GI bleed, you will find E by E prime has gone down, E by A has gone down, and the LVOT VTA has gone down. So I think let us stick to echo-based hemodynamic monitoring and apply it on all the subsets, and let us not give labels. Labels are easy to put but difficult to remove, you know. And the moment you put a label, you lose a patient. Then you say uremic cardiomyopathy, then nephro and cardio become king. So no, intensivist is the king. You just keep the patient with you and keep doing your echo-based hemodynamic monitoring.
And is it the same like most of the nowadays the cases like viral myocarditis, say COVID myocarditis, or so?
Yeah, so if you find a patient of COVID-19 who's come into the intensive care unit, one is, you know, everything looks good. Chalo, you can routinely screen. Somebody is learning to do the echo. That is one. But suppose this patient becomes, say, hypotensive, or the patient has got borderline pressure, and you find that the LV is dilated, the RV is dilated, and you find that the EF is low and it is COVID, you will not have adaptive LV dilatation. So if the EF is low, the stroke volume will be low and the cardiac output will also be low. This is not a septic heart. Then you can say it is a myocardial dysfunction due to COVID. And then you look at literature, because COVID-induced myocardial dysfunction or COVID-related myocardial dysfunction is a safer term. But whenever we are using any myocardial dysfunction in the ICU, at the back of your mind, the last thing you have to write is rule out acute coronary syndrome. You know, so patient should not go home without a proper workup for coronary artery disease. Now, other than that, you know, if it's a global LV and RV dysfunction, and then the patient is in a setting of COVID, then you know it is COVID-induced myocardial depression. Then you look at whether the inflammatory markers are raised. If the inflammatory markers are raised and if there are arrhythmias, and you know, then you take a call whether this patient, does he need pulse methylprednisolone or a IVIG. So I think don't use labels. You just say in a setting of this, I am finding this. First thing, do I need to rule out acute coronary syndrome? That should not be missed, because in your label, if a patient has a STEMI and dies, then you know you can get sued. So that should not be missed. But you then follow up the patient. That's it.
So for the benefit of our students, some of the students have requested what are the different books to read for echo, and the paper you have mentioned, Dr. Prajakta also asked for what is that paper which you have mentioned in your discussion.
So you send me one of you, Gunadhar, you send me a request on Dr. Vivek MD at Gmail. I'll share Daniel DeBaker's book with you and you can share it with everybody on Gmail. Okay. I think that's the best book. And if you still have doubts, I mean, try to be in touch. There will be a workshop this month, but then that's going to be expensive. Otherwise, we'll keep having interactions. But Dr. Daniel DeBaker's book is there, echocardiography based hemodynamic monitoring. I think it's a 2012 edition. It's still about 12,000 on Amazon. I'll share it for free because it was shared by one European only with me. I'll share it with Dr. Gunadhar. Read the book and use it. If you have any doubts, you can get in touch with me.
Yeah, thank you. Thank you. I think
Really, thank you.
that will be great help to all the trainees.
So I think there are no more questions. With this, we would like to thank you, Dr. Vivek, from the bottom of our heart. I mean,
It's a
I can't
eye-opening
express.
basically.
Yeah, but really mesmerized today.
All these, you have also seen all these patients. Gunadhar has also seen all these patients.
Yes.
It is that work which I have put together and, you know, analyzed it after so many years, means over the last 3 years or so.
So anyway, at the end, I need to thank you very much for on behalf of our group, and we'd like to keep listening to you. You know, one of the colleague already has written that he would like to hear from you more often. So it is really from I think Dr. Satish from Kerala, I guess.
Yeah, no, I think I'm trying to clear doubts. If you ask me the next talk, I will plan maybe a couple of months down the line will be a stress cardiomyopathy, because you know
everybody will going to have in the future.
Labels. They're all very confusing labels for the intensivist, and they are all MCQ questions in the board exams. So you know, yeah, gives me I have some loops again, and we'll work on it maybe couple of.
Sure. And I will also like to invite all of you and Dr. Vivek also to our next session on this quality indicators in the ICU. It is going to be one of the very interesting talk. So I request all the delegates and our speaker also, if he can be available for the next session or the next Thursday, same 7 o'clock.
Okay, Gunnar,
Sure,
just
thank
send you all the questions on chat box. Okay.
Yeah.
Okay, chalo. Thank you, everybody. Thank you for your time.
Thanks.
Thank you very much. Thank you. Good
We are
night.
your great fan, Vivek sir.
Thank you, Jay.
Yeah.
Thank you.
Okay.
So I conclude the session. Thanks.
Yeah, we'll conclude this. Thank you very much again. Thanks.
Bye.
Good night. Good night. Good night. Good night. Good night.